move to the second trial. It's an EORTC trial, which included a very large number of patients, patients with positive lymph nodes or negative lymph nodes in central or internally located tumors, were randomized into breast radiation versus breast plus regional lymph node. And the regional lymph node included supraclave and the IMC. So here the IMC was very much targeted. The main endpoint was overall survival, and the secondary endpoint was disease-free survival. So it took 8 years, but they collected 4,000 patients with lumpectomy or mastectomy. That's in contrast with the Canadian. They had only lumpectomy. So here they included mastectomy, stage 1, 2, and 3, with a median follow-up of 10.9 years. Very solid data, long-term data. Now, since this trial went over a long period of time, so you have the 2D in the beginning, the 3D at the end. So you have this mix of patients regarding the technique. But I want you to pay attention about the technique. They had a direct IMC field shooting straight to the heart. And here we have to be careful, even with the electrons. But maybe they had some restriction that the dose used by photon irradiation to the IMC was probably restricted to 15 gray, not too much. But this is the technique they used, probably different than the technique used by the Canadian. And again, the EORTC extended the lateral field to cover the whole axilla, which was in contrast to the Canadian. So the data showed that there is a significant increase in disease-free survival at 10 years with the p-value here, but I'm sure you noticed that in absolute value it was very little, like from 69 to 72%, so 3 percentage points. That's in contrast to the Canadian study, which showed at least 8 percentage points. And metastasis-free survival was also significant, and overall survival was better, but was very much borderline significant. So both studies, very large number of patients, they go in the same direction. Regional lymph node radiation improved disease-free survival. And we could think that there is a benefit from regional radiation because usually if there is a persistent local regional disease, which is not irradiated in high-risk patients, this can lead to regional relapse, and this in turn can increase the rate of distant metastasis. However, both studies are not published yet. So what do we do today? Knowing that we know the data because it was presented several times, but it's not published. Some people would continue to do what they do until the data is published.